You are listening to the
World Extreme Medicine.
The World Extreme Medicine
Podcast.
In this episode, we're going to explore the rich diversity of nursing roles within humanitarian space, but also the underrepresented yet critical components of global health efforts that the nursing occupation both inhabits and indeed embodies from a number of different aspects. So from conflict zones to neonatal units in remote regions, nurses are at the heart of delivering care, education, and advocacy in some of the world's most challenging environments. So today we're joined by two leaders within the field, Marcus Wootton, Associate Director of the International Academy of Royal College of Nursing, with a career spanning war zones, global education, and refugee advocacy. We're also joined by Elsa Afonso. She is the head of the International Academy at the Royal College of Nursing, whose expertise bridges neonatal intensive care, international training programs, and global research. So together they bring decades of frontline and indeed strategic experience across organizations like Médecins Sans Frontières, UNICEF, and indeed leading academic institutions. So in the conversation, what we're going to do is really unpack what it means to be a nurse in the humanitarian arena, but also how the role goes far beyond the bedside to include system development, cross-cultural leadership, and ethical advocacy. Welcome to the podcast, Marcus and Elsa.
Thanks very much. Lovely to be here.
Thank you.
It's great to have you both with us, actually. I wonder if we could actually just start with your backgrounds. If we could just really start to unpack what drew you into humanitarian nursing. Maybe, Elsa, if I get you to go first, and really your early experiences and how it shaped your approach to global health.
Yeah, thank you for that question. I think that even really early, before I even decided I was going to be a healthcare professional, I wasn't sure whether it was going to be nursing or medicine or any other. I knew that some sort of international work would be in the cards. When I was in college back in Portugal, that's where I'm from. I did a bit of volunteering with the local NGO. We did lots of fundraising and networking with local NGOs, visited local hospices and halfway homes. And I did this for 4 years before I started uni. And in uni, interestingly, we do general training in Portugal. And I was always drawn into placements where we worked with disadvantaged communities. And I remember one particularly interesting, which is in a place called Zona Jota in Lisbon. It's a very disadvantaged area. And I was doing a children's community placement. And I remember driving in areas where you would get mugged if you weren't representing, if you depending on what you were doing, and being told that if you're a nurse, you're here for us and nothing will happen to you. So I suppose that there's a lot of power in hearing that when you're 20 something and knowing the impact that a nurse has in these areas. You kind of wonder, where else can you make a difference? And it evolved into going abroad and get like a full-blown humanitarian work in the field, which was life-changing. And to be honest, and something that anyone who is considering global health experience should consider. But it developed into something more mature. So something that how I can use my experience and expertise to make some structural differences in health and nursing globally. That's kind of what took me to where I am now.
Yeah, absolutely. Marcus, yourself.
So I had a slightly different route. I'd left school and had a place to do a politics degree. And in some ways, in the job I do now, maybe a politics degree would have been more useful. But I think, if I'm honest, that was probably just to keep my parents happy. So I decided to kind of take a year out. Initially went traveling to Vietnam to teach English, and then through a series of sort of complete random chances, found myself looking after children at the Christina Noble Children's Foundation in Ho Chi Minh City, in Saigon as it's known. And many of these children were really exceptionally disadvantaged, and clearly at a kind of macro level, this was at least partly because of Vietnam's history and the war and the sort of residual impact of that. And that was around the year 2000. So that was, a very long time after the end of the war, at least 25 years. And yet it still echoed. So that rather pushed me away from politics towards something a bit more practical. And I think of myself, I know that I'm really at heart arts and humanities rather than science. And so I wasn't really that interested in all the different things the liver or the kidneys did, but I was really interested in people. And just how unprepared I was for nursing would be manifested in my A levels, which were woefully inappropriate for anything science related. So I slightly unbelievably, Liverpool University let me in, and I think I was the 41st person of a 40-person course, which is a real lesson actually to anyone, in terms of, if somebody turns up who, isn't perhaps who you think they might be, that you should probably let them in. And when I got there, like, Liverpool's this amazing global city, and it has this really rich history. It's like the oldest Chinese community in Europe, and at the time I was there was lots of work going on with Somali refugees, but it also has this really massive, wide social gradient, and there's some areas of real luxury, but there's also really awful poverty, and it's all crammed together in really quite a small area. And then alongside all of that, there's this astonishingly brutal legacy of slavery and then colonialism, which is so apparent in Liverpool, in these grand squares and buildings that were built on the back of all of this. And so in terms of nursing, what was really clear to me, and became clearer as I went through my degree, was the sort of positive roles that nurses were playing in those communities, and the idea that in reality we're all really global nurses. I don't think anyone can really not describe themselves as a global nurse. So these sort of two things combine, really, the really visceral experience of the damage that can echo from a war and a humanitarian crisis, even years later, and then the power of healthcare in general, nursing in particular, to be a force for good in the world. And I suppose that's probably as much as I can sort of conceptualize how I got to this place.
Yeah, indeed. No, indeed. And that completely makes sense, actually. But could I get you to speak to, could I get you both to speak to, really, just how your clinical background in neonatal care and, outreach nursing and otherwise has prepared you? Actually, thinking about the question, did it prepare? Can you ever be fully prepared for a career in a conflict zone, or indeed a resource limited area? We were just talking about this offline, about you prepare as much as you can, but and it informs you, but whether it truly prepares you. Elsa, to yourself.
Yeah, I suppose, it's an interesting question, because it sort of prepares you, but not in ways that you're thinking, I guess. So before I worked in humanitarian aid, I experienced nursing in 3 different European countries, and nursing in a critical care, both adult and neonatal, Portugal, Belgium, and Ireland, and we have this preconceived idea that Europe is quite similar in itself, but it's not. There's quite huge differences between countries. And my experience in Belgium was very short, and it was in the context of a short kind of stay. But it was the first time I ever lived in war nursing uniform away from home. And I knew 3 sentences in Flemish, and none of them were related to healthcare. And the challenge there was to adapt to a new system and to a foreign language, and not having any familiar environment to return home to in the evening, regardless of the experience that you had on that day. And it was frightening at first, but probably planted the international seed, and that little voice saying, oh, I could do this. This is interesting. This has something to it. And when I started working in a NICU in Lisbon, I almost immediately started planning my exit. And I studied tropical medicine, joined a humanitarian agency. Turns out I wanted to study a bit more, so I wanted to learn a bit more, because you do have, I suppose that when you're exposed to a different environment, you know what the pitfalls you can have, so you want to prepare. So the feeling unprepared leads to try to get better preparedness. So I did global health in Dublin. That was the only place that was in Europe that the global health masters was taking place. And I worked there because I don't have rich parents, so I had to pay for my education. So I went, and I gained exposure in a neonatal intensive care unit. And I'd say that while NICU skills, because they're so specific, it's very technical. You have to look after very sick infants and their families. It's not just the patient; it's the whole complex situation. It does help. It did help a lot. But I think it was more overall behavioral preparedness of shifting contexts, and that was more crucial to prepare me for work in humanitarian and complex environments. I went with a preconceived idea that all I would struggle with was the language, But the hardest thing was to navigate some cultural differences and barriers that came from working with staff and families from different backgrounds. It was not just the country that was different, it's a very multicultural environment. And I had to shift approach depending on who I was looking after, and I wasn't prepared for that. So I kind of had to adjust my expectations of what I could do, and also understand that, one, you don't always know as much as you think you do, and you don't always know what others know, so you kind of have to be adaptable and flexible, and sometimes be prepared to make mistakes, to bend rules, but to also explain why you're doing that in a foreign language and a different cultural context. And for me, that was the biggest learning that I had until then. And it kind of prepared me for the work with MSF, which was what came next.
And Marcus, to yourself.
Yeah, so for me, after Liverpool, I came back down home to London, did a paediatric nursing degree, and was doing sort of jobs around that, and being a bit restless, fell into accident and emergency, or maybe it found me, I'm not quite sure which. But I love the variety, I love the problem solving element of that, and I think you can definitely apply those sorts of things to conflict. But having said that, I did a number of other jobs as well, sort of, they call it now side hustles, I'm not quite sure what I called it then, and there were lessons from those kind of jobs that I took with me. So not least, I worked for a company that did flu jabs for city workers in funny places like big tall office blocks and, you know, the London Underground and various other things. And so that taught me, you know, how to sort things out so I could jab a lot of people very quickly and very and safely. And it teaches you that, you know, vaccination is really 95% logistics and 5% clinical. So a wide variety of clinical experience, I think, really can help you prepare. But it shouldn't be that you have to think that you have to, you know, work for 20 years in a well-resourced setting. I think just having a decent variety of things is useful. And then alongside that, did a diploma in tropical nursing at London School of Hygiene and Tropical Med, which is a qualification designed to prepare people for work in low resource settings. And it was really excellent at doing that. And so relating all of that to conflict, obviously emergency helped, and it would help me sort of work out who was sick and who wasn't. It was useful to be able to look after sick adults and sick children, and understanding diseases like malaria and dengue and Kala-Azar and, you know, the weird and not so wonderful tropical diseases was quite useful. But I think you alluded to it at the beginning, and I really like what you said, which is that I don't really think you can be kind of over prepared, and I don't think there is anything that fully prepares you for the situation that you know will eventually find yourself in. And I think it's really important to recognize that before you go into this, because otherwise you're kind of setting yourself up for failure. So recognizing that you can't know everything is probably just as helpful.
Yeah, absolutely. No, absolutely. And actually, to your point around some what others might seem as quite mundane experiences that can actually inform future practice, and actually it'd be really nice to hear. So you did some work in Vietnam, and then also with MSF in South Sudan, treating war victims and indeed supporting vaccination campaigns in those countries. And could I get you to speak to some of the lessons that you took away from these high pressure environments, and indeed that maybe still inform your practice today?
Absolutely. So I think if we start with Sudan, Sudan is an astonishing country. It has this real richness of language and of history. And I think the first lesson I would say is really get to understand that, like really get to know the history of the country and the politics. It staggers me how many people go abroad to work without even a rudimentary grasp of the history, who the president is, who the prime minister is. Can you draw the flag? You know, is it a democracy? How's it governed? How's it run? Who were, you know, in some cases, who were the colonizers? So the first lesson I would say is clearly do your homework. In terms of conflict lessons, I think the one thing that I sort of started off, my misconception when I started was I thought I was going in to be dealing with lots of ballistics injuries and shooting. And actually, you know, that's really not the majority of what you're dealing with. What you're dealing with is a health system under stress, which has then got the conflict layered on top of it. It's the other stuff that's much more common. And actually, we've seen this massive shift historically because, in the 19th century, about 10 to 15% of all deaths were civilian, and now we're nearer 90%. And so I think what you've got to recognise, and what we all need to recognise, is that a health system collapse runs parallel to the armed conflict. And it's pretty inarguable that nurses are the most important health workers in any health system, really, by dint of their scale of operations. So those two things kind of together, I think those are important lessons to take forward. And then regarding vaccination, which you talked about, and I mean, it's funny that you said taking the lessons from slightly more rudimentary jobs. An arm is an arm, right? So they're definitely getting people to queue up in an orderly way is what it is, and it doesn't matter if these are underground workers who are coming up from wherever, or these are city bankers, or these are very, very, very desperate people in the middle of South Sudan. And so we have to recognize that actually lots of things are common. Vaccine hesitancy is a common thing everywhere that I've ever worked, and it's really significant, and it predates the internet. I'm old enough to remember the MMR disaster and all the Andrew Wakefield stuff that we had in the UK. And for those who aren't, I'd suggest looking it up. But nowhere is, for want of a better expression, immunized from that worry. And we alongside that, we have to consider that vaccination in conflict and humanitarian settings is really difficult, particularly if you're trying to maintain a cold chain, and sometimes it isn't possible. So we have to build a health system that's resilient enough to cope with outbreaks, and particularly lots of children becoming very sick very quickly. And again, that leads back to the quality of the health system, and again, that sort of leads us back to nursing. So these things are always running kind of concentric circles. And I think it's really important to recognize that in conflict, it's the direct casualties are part of it, but the far bigger issue is, as I've said, all of the issues around system failure, and that nurses need to be really placed at the very center of that response. I will leave you and your listeners to decide whether you think that's what's currently happening or not, but that's the situation as it should be.
So Elsa, you mentioned earlier around cultural appropriation and just having an idea and a revelation of just the culture you're stepping into. You managed HIV and AIDS programs in Zimbabwe, and indeed have supported neonatal care globally. Could I get you to speak to what successful leadership in some of these different cultures looks like, like you said, just entering into and having an idea of this cultural appropriation to then deliver care in some of these very difficult settings?
Yeah, absolutely. And I think that picking up from what's been said around what preparedness do we need to have, and then nothing really prepares you. Leadership is one of them. You might have seen and witnessed and experienced leadership, particularly in nursing and in healthcare, in a high income setting. And as soon as you go into into different parts of the world, then that kind of shifts. But if there's one thing that I want to pick up for what Marcus said, is that, I mean, the minimum is to get to know a little bit about the country that you're stepping into, because then, you might say things that can't be unsaid, or you might do things that can't be undone. So I think that going with a bit of caution is important. To start with. And when I worked in Zimbabwe, and I think that was the biggest, like the first kind of shock in terms of what taught me more lessons in terms of how leadership can look differently. And this was back in 2010, and I managed the nursing and pharmacy components of a national HIV and AIDS program. And there was a bit of leadership in a clinical multidisciplinary team with my medical colleague. Most of the team was made up of nurses. There's a couple of doctors, but and in these settings, and also in Botswana, I've also co-led a neonatal education program for nurses and midwives. But leadership in these settings is sometimes slightly more horizontal and improvised, meaning, the expression learning from experience really makes sense in these, and you kind of have, like I said before, to go a bit careful, because you're being figuratively slapped in the face by the need to make decisions. And often you do this really early in your career, and there's people around you that are doing it really early in their career, or without any preparation. And this happens a lot, and with no practical or theoretical leadership preparation. I recall a particular situation on my second week in Zimbabwe, where we went to one of the remote clinics that was near Wangi National Park, pretty much the Kalahari Desert. And we were going to check the stock of malnutrition supplies, the ready-to-use therapeutic foods, and just chase some follow-up patients in our prevention program. And after a good 3 hours of driving in the middle of the sand and bush, we arrived at the clinic, and what we faced was with a massive malaria outbreak. And nothing had prepared us for that, not equipment, nothing. And essentially, there were dozens of patients lying on the ground struggling with really high fever. And there was loads of people needing transportation to the hospital, but there was an ambulance, the only ambulance that they had available had run out of fuel, as was a common event. And they didn't have a landline to call the hospital, the district hospital, for backup. There was absolutely no phone network. So we could only transport one patient in the car, and the clinic nurse asked me to put a cannula in some patients because she couldn't do it. And I was not allowed to do it because these are the situations that my Zimbabwe registration was, they're very strict about what international nurses can and can't do. So I could not do it, otherwise I would get into trouble. And they were just asking me to make a decision and to support them in making a decision. So this is still a case study that I teach my students that are doing international nursing, and ask them what they would do in this situation. And despite minor differences, most of them still make the same decision that I made, which makes me kind of hopeful, which was to instruct and support the staff nurse to insert a cannula and calculate fluids if they're available, to do a mini briefing on how to report the outbreak, to call the district hospital by satellite phone because we had it available. Most students don't even recognize that we might not have internet 4G or phone reach. So they just pick up their mobile phones and call someone, which is not possible. And that we asked them to send available ambulances and prioritize the patient you could carry, which in this case was a pregnant woman, which we did carry to the hospital. But the highlight is that because resources are scarce and you're in a limit situation, decisions must be shared, and the decision was shared. And none of us was prepared for that, but we just trusted each other. We trusted in each person's skills and what they could do, what they couldn't do, what did we have available. And there was an understanding coming from that shared purpose, and it didn't come from titles or roles. And that sort of leadership is useless in these contexts. And actually reversing back to the hierarchical leadership is really hard. So I suppose, yeah.
If anything, as well, Elsa, that just illustrates the behavioral flexibility and like you said, thinking outside the box, and actually being confronted, which seems to be a common theme actually, with a whole clinical pathology or string of pathology which you weren't anticipating or expecting, but having that flexible approach where you can delegate and democratize and even just share the mental model and come to some shared understanding of the next steps is absolutely key. I'd just like to pivot slightly, and Marcus, I'll come to you. Just around a key theme from both of your careers, really up until this point, is education. And from international exchange to lecturing globally, could I get you to speak to how you see the role of nurses changing and evolving as educators and mentors in the humanitarian context?
Absolutely. I think, education, as you say, has become this kind of, it's a really important thing for myself, for Elsa, and actually for all of us at the Royal College of Nursing, because it's an area where I think we can have the most impact, meaningful impact in many ways. And just to start things off, I think some people have the perception that nursing is this terribly ordered profession, that you've got these cliches about starched uniforms and hats and all that kind of stuff. And the reality really is the birth of nursing in a modern context came from the Crimean War and the work of Seacole, Nightingale and others. And so we think of nursing as this kind of very ordered, very sort of regimented profession, but actually it comes from this area of total chaos, and it wouldn't be the profession it is now were it not for that. And so the kind of the chaos of the humanitarian context and the role of nursing, I think, are really intertwined. And I like to see nursing as a sort of expression of humanity, that actually it's a really nice expression of humanitarianism and people doing good in the world, which I think is really helpful, obviously. And so growing the next generation and improving the role of nursing is not an optional extra, it's fundamental. And we all nod at that, you're nodding at that, we're all nodding at that, but actually, it's interesting then that you then see how little focus any education gets in humanitarian crises and conflicts. And if we think about any conflicts in the world that you care to mention, and anyone think about it now, what focus is there on health education? In any news story, the most you'll get is a report from a hospital that's been bombed, and that frequency focuses on surgery because that's the place where people tend to go. But we don't, and we see the damage to the hospitals, but what we don't see is the complete destruction of any continual professional development for existing staff, which is really important because you might have a health workforce that's completely unfamiliar with, for example, war injuries and ballistics and that kind of thing. And that's definitely what we found in Myanmar, where we did a lot of our work, that suddenly they're having to pivot towards a completely different situation. And then further to the thinking from that about the kind of upstream stuff, where's the next generation coming from? The average conflict lasts for 11 years, which is basically 2 rounds of training a doctor for 6 years, or it's 4 rounds of educating a nurse. And in many countries, they didn't have enough nurses to start with. And now it's possible to articulate, I think, a very coherent argument, which takes us from a weak health system and a lack of health workforce, which provides just the sort of environment where countries can fall into conflict in the first place. So the two are kind of, in some ways, sort of help to make things worse, in and of themselves, really. And so what's interesting is in the response in terms of educating the workforce. And we saw this in Myanmar. And the response from the international community is to go for short-term education of health workers, air quotes, who get trained for a few months and then sort of thrown into the health system. And when you do that, you get exactly the sort of outcomes that you would anticipate that you would get, which are that they're not terribly good at reducing mortality. Best example of that I can think of is traditional birth attenders, who, for those who don't know, are health workers who are trained for a short period of time to deliver babies. Now, it does depend slightly on what paper you read, but the consensus generally is that certainly in the case of maternal mortality, they really have the impact of traditional birth attenders, TBAs, has been negligible. And it's not their fault. It's just an inescapable reality that you can't have a quality health system on a foundation of workforce who haven't been educated for a decent amount of time. And we just need, as a world, to get over that idea that you can just, pile it all high, sell it cheap. There's a shortcut to an educated and high quality workforce, because there just isn't. And so aside from that, I think there's a real moral hazard here as well in throwing people who haven't been educated to a sufficient level into a health system that's then got all the stuff going on about conflict and all the challenges that we've described, and Elsa, you described in your malaria example. If you hadn't been a nurse in that context, what on earth would you have done? How would you have coped? And it's all on this rather misguided principle that anything's better than nothing. And so if we start our educational point not from anything's better than nothing, but how can we get the highest quality health worker into this system as efficiently and effectively as possible? And so in Myanmar, it was clear that to do that, and it was actually required us to do the heavy lifting, because the prospective workforce was already there. They had a bright and resourceful group of school leavers who could be educated into a nursing workforce. And so at the Royal College of Nursing, alongside many others, we've been supporting multiple courses of undergraduate nurses to be educated to a degree level through a hybrid model of online and in-person education and clinical placement as well. And as of today, we have 77 nurses at some stage of that programme. With some only a few months away from qualifying, which will be great. And so what that says, I think, is that it is possible. I won't pretend for a second it's easy, but it is possible. And we really, as a world, need to reshift our view on what is possible within a conflict zone or a humanitarian crisis around education, because We need to think about nursing, medicine, physiotherapy, occupational therapy, all of those kind of things, and pharmacy, as essential to rebuilding the quality health system.
Yeah, and can I just, I agree, and I think that, of course, your experience, that you have a lot more experience in conflict areas, and I think that even in those situations, or particularly in those situations, this perspective is really important. But even when you go to more stable environments, and when you go to low middle income countries, this perception that we can offer short courses and that will do the job is still a common thread in Botswana, and the program in Botswana was wonderful, and it helped the workforce in the neonatal workforce massively. So we had an education package which initially at local request included resuscitation and emergency, because those were the key things they saw that they really needed support with. But then it became clear that the needs were much more extensive, and that what was needed was a baseline knowledge of how to handle a sick or preterm neonate. And while the training was adjusted and the team found it helpful, what would be needed was a full specialization. In the UK, if you want to work and progress in a neonatal intensive care unit, you are required to specialize. So why would a low middle income country be any different? Why would we set different standards? And because knowledge is power, it increases the value of these nurses and supports retention and career development, and it creates equity in the workforce. So education is not secondary in humanitarian context. It does create a strong basis to help prepare for any circumstances, because nurses are 70 to 80% of the workforce, and they are the ones who stay and who continue to deliver care.
I think that's powerful for a number of reasons, actually, and to both of your points. Actually, in the humanitarian context, competence and confidence actually is actually even mandated even more, because with a removal, or indeed you haven't got the access to the diagnostics, you have a critical mass of demand, which often outstrips supply. As you said, there can be a prevailing political or geopolitical pressure which might not be existing in an established or stable democracy. So there's all these different factors at play which it can interfere with practice, and actually sometimes make things a significant amount more difficult. But just something, Marcus, just to pick up on, and Elsa, I'll come to you actually for this. Marcus, you mentioned, just competence, and this central theme of competence, and actually how competence can't be circumvented, and actually the elongation of not necessarily exposure, but learning over time, reflection, feedback, mentoring, all these elements which multifactorially go into competence, actually can't be circumnavigated. You can't shortcut these, because actually if you do, like you said, you end up shortcutting and/or affecting morbidity and mortality, and actually it's prudent to give credence to all those factors, irrespective of context. But could I just come to Elsa? Could I come to yourself, because capacity building has also been a theme of both of your careers, and you've been involved in capacity building programs. Could I get you to speak to, and it really aligns to what you've just been speaking about around sustainability, but also longevity. Could I get you to speak to really just how you create a sustainable and culturally appropriate program that with local communities that endures over time?
I think we probably need a paradigm shift, and it is happening slowly, but there's a lot of constraints that, particularly funding and in global health, that restrict what is a priority and how we do needs assessments. Who decides what the priority is, and who decides the way forward in any global health initiative, particularly at local level. So this decision of where the needs come from, and then going from those needs to the solutions, or who decides which solutions work, is a difficult one, because obviously there is a lot there is a lot of decisions that need to be made from an area of expertise and experience, which comes probably from a global discussion. But then there is a lot of conversations that need to happen at local level to understand what is the appropriateness, what is the sustainability, and what is how does those solutions fit that environment. So suppose shifting from to a conversation of systems thinking and partnerships is something that at least us at the RCN, and I think a lot of global health stakeholders are shifting towards. Yeah, so I don't know if Marcus.
Oh yeah, I was just going to pick up on that. I think it's such an interesting element, and I'm going to be slightly rare for an interviewee and not propose an answer, but just to propose a problem, which is that there is a real tension between the balance to respond and also to be culturally appropriate. I mean, there's no point flying halfway around the world to sit in a room and say to everybody, well, what do you all think? Because that's not really very helpful. But equally, telling people what to do isn't helpful either. It's versus being a passive facilitator through a decolonizing lens, and recognizing as well, I think this is something that certainly in my career I have thought about a lot more, recognizing the damage that we have done not only in our colonization but also in the years afterwards around aid and some of the ways that we have used it, and then also how that has run parallel with some really appalling asset stripping practices, particularly in nursing. State of the World's Nursing Report this month shows 1 in 7 nurses working in a country they weren't born in. I'm sure many of the people listening to this will be working or know of nurses who were educated in a country that really needed them and are now working in a country that's very high resource. And I'm not for a second saying that people shouldn't do that, but I am saying that the compensation around that is inadequate, given the amount of investment that went into educating these nurses. And so I think we need to be very, very aware of that. And even in the way that we project ourselves, one big thing is just a really simple thing for me that sort of helps is to think about using local guidelines wherever you possibly can. I know there are some NGOs that will go in with their own guidelines, and I would say, bluntly, I'd say that's a mistake, because I think what you're doing is you're undermining the local doctors and nurses who may well have a very small society of paediatricians or of nurses or of whoever, and they might be working on some guidelines, and they might not be perfect, and they might not be what you do at home. Their algorithm might be slightly different, but it's their country and it's they are their patients, and going in and just saying, well, I've brought this algorithm from the UK and this is what we're going to use, all that's likely to do is to sow confusion, when actually what you really need is clarity. And it's very hard to build any quality improvement and capacity building on a foundation which isn't clear. And so for those sort of clinical guideline stuff, I would make a plea to anybody going anywhere. The first question you should be asking is, well, tell me what you use currently. Now, if there's a gap, work with them to identify what to do with that gap, how to fill it, how to change it, whatever. And that's something that I've done in many contexts. But start from the principle that the doctors and nurses in the country know an awful lot more about their country than you do. Obviously, sounds obvious, isn't always practiced, and that should be the basis of your capacity building. And be honest. I think the other thing I would say is I have made much more progress when I've said, do you know what, in the UK we tried whatever it was and we really screwed it up, and this is why we really screwed it up, and I would avoid making these mistakes. Being honest about our failings as well, I think, could be really useful.
Yeah, I suppose that when you say that you're going somewhere to teach people how to do something, I think that's when you start off wrong, isn't it?
Yeah. You're on the wrong foot from the start. And I really like that point actually you make, because like you said, it's based on a lot of subconscious biases and assumptions that, like you said there, that a guideline fits into maybe a network or a system of working, but actually the appropriation or the understanding of that network just takes time, because actually, like you said, the UK might operate in a completely different ecosystem. And actually the guidelines need to, they're actually, it's that active listening, and it's actually understanding, and to your point, to both of your points about observing, just observe and actually be quite slow on the approach, actually, is key, I think. Marcus, I'd like to pivot slightly and just look at, you've done work with medical justice supporting victims of torture in the UK in immigration centres. And again, that brings a different lens to humanitarian nursing. Could I get you to speak to really how nurses can act as advocates in politically sensitive environments?
Absolutely, yeah. I mean, I think for that one, I mean, I would start off by saying that when I did this, the immigration debate was not in any way as toxic as it is now. And just to explain what immigration removal centres are, they are, to all intents and purposes, prisons. They're built like a prison. They have high walls, they have multi-doors to get in and out of, and they are there for people who have either failed an asylum claim or have claimed asylum, and for a series of reasons have ended up being held in one of these centres. But they are also the place, and this is really important, and most people don't know this, for foreign born prisoners who are also awaiting deportation, having served the end of their sentence. They're a place for them to be placed as well. So what you have are an incredibly vulnerable group of people mixed in with former prisoners. And it's a very, very complex debate, but the route that I was taking with it, and the way that we were working, was actually relatively simple. And it was that those with a clear evidence of torture, or those under 16, shouldn't be held in an immigration removal centre. And I think when you say that to people, they're often quite surprised that that's even a thing. But myself and my colleagues were finding multiple examples where this wasn't the case, where people were being held in these removal centres despite having really significant evidence of torture, obvious, either physically or mentally. And some of medical justice work fed into the Brookhouse inquiry, which was an inquiry set up to look at just one immigration removal centre in a very short period of time in 2017. And what that found was that there was this really toxic culture with staff. There was a prisonization of the unit. There was racism. There was stereotyping. There was verbal abuse. Really awful dehumanizing behavior, and at least I looked this up, but at least 19 separate breaches of the European Convention on Human Rights. And I think if you've got 19 separate breaches of anything, that is pretty indicative of a system that isn't functioning. And all of that would not have come to light were it not for the work of health workers, including nurses. So I think the lesson to take from that is that our role in this is pivotal. Really sadly, the latest update from 2024 shows that actually most of those recommendations that were made, which were made in the inquiry, it was judge-led inquiry, and they were not implemented currently. So I think the first thing I'd say is that advocating as a nurse can be a really long, hard slog. And the speed of the response almost never matches the urgency that you see. I saw people in that place, and I thought, I need to get these people out this afternoon, and it would be months before we could finally get them out. But in my career, I've always been really led by the phrase, if not us, who, and if not now, when. And I would say that some of the work that we're doing now at the Royal College of Nursing, which is highlighting nurses in conflict, highlights a similar pattern. Thinking about using data can be really effective. So one stat that I would say about that is, when we're thinking about nurses in conflict, in 2021, 201 health workers were killed in the course of their duties across the world, and by 2024 that number's risen to 922. And you'll notice I say health workers because the data isn't available to tell us which cadre of staff that was, so whether it was nurses or doctors or paramedics or who they were, but we do know that our profession made up a really significant proportion of that number. And so I think the first thing in terms of advocacy, I would say, is it's a really long slog. The second thing is using data is very important. But the third thing is to recognize as a nurse, you are one of the most trusted professions. You know, health workers appear right at the top. I won't say who appears at the bottom, but you know, health workers are right up there at the top. And actually, as nurses, we are right at the coalface of a lot of this. We have access to people in a way that almost no other profession does. And so it really is sort of, it is very, very important that nurses advocate for the situations they see, for the patients that they come across. And our input is really essential, and it's really vital, because sometimes there isn't anybody but us.
So just pivoting slightly, actually, Elsa, and looking at your work supporting health programs in Sri Lanka, Malawi, and other UK overseas territories, could I get you to speak to, I guess, really from your first-person experience around how the role of nursing differs in these contexts, or indeed stays the same, just if there's any universal principles, just in these varied geographical and political settings?
That's a really good question, and I think that often one thinks of nursing roles as in what can nurses do and what they can't do across the board. Obviously, with some differences around skills and competencies, which there are, particularly depending on whether nurses are general trained, branch trained, etc., which there's quite a variability geographically. Their main disparities are around three aspects: career progression, recognition of professional recognition, and remuneration. And I found that nurses' clinical skills and knowledge, despite some differences, as I say, related to the degree of training, but they're quite similar across the board. And many times they are superior in what we call the global south, because of the transferability of the roles and task shifting requirements. As Marcus said, they're often the only ones, so they have to do the work. So they have to know how to do the work. What changed are working conditions expectations, and this says more of the health system than the nurse itself. What they're allowed to do, what nurses are capable of doing, says more about their environment than of themselves. So, for example, nurses in Zimbabwe were trained in 2010 to prescribe antiretroviral therapy because there was no doctor, but they earned at the time less than 50p an hour. In Portugal, the issue of nurse prescribing is still under massive discussion, and Portugal is a high-income country, and it's still a taboo in the medical profession. So it's still an issue of career progression, of recognition. In the UK overseas territories, for example, we're still kind of assessing the different responsibilities that nurses have, and that it's very challenging to get full data on this. But it all suggests that they might be accumulating functions because they are the only healthcare professionals available, because these are often remote areas. So they're dealing amazingly with all sorts of issues because they are the only healthcare professional available. So their roles are very different from the ones we have here in the UK. In Sri Lanka, for example, primary care has been recognized to a specialist level. So nurses are specialized, have a postgraduate certificate. However, they still earn on average 10 times less than a medic. And so there's quite a discrepancy. In Malawi, there's a government CNO has significantly less power than other professionals, and nurses are discouraged from publishing research in medical journals. So they have created their own journal, and they asked us to help out. So there is this appetite to progress and to have more recognition, because actually, across the board, they are, often the nurses who have less recognition and less career progression are the ones who are dealing with more complex issues. So it's kind of, difficult situation.
Yeah, absolutely. And to your point, there's such a wide disparity, but like I said, not only of recognition and of training, but for instance, in Malawi and Blantyre, in Queen's Hospital, there's a real lack of nursing. So often the family has to give medication.
Yeah.
The family has to step up and do self-care or indeed care of the patient. And so there's almost even a complete absence of nursing. It's doctors and pretty much cleaners. There is no nursing, and so there's such a wide disparity of service delivery, of supply, and like you said, of competency and ability to recognize the vital role of nurses. So it is a complex environment. Absolutely, absolutely. Could I just pivot slightly and look at the role of one of the things that's really coming to the fore in out of hospital care at the moment is the concept of MDTs, and how significant multidisciplinary teams are in delivering care. And Marcus, I'll come to you just really and get you to speak to really the multidisciplinary collaboration that you're seeing in the humanitarian context. Is it evolving? Is it starting to become more prevalent, more accepted, more practiced in humanitarian aid?
Absolutely, and I think there is still some distance to travel, but I think we are starting to see some really interesting innovations in that way. Just to speak to the point about nursing representation, I mean, I would ask everyone listening to this to conduct a little thought experiment as if, and imagine if nursing was 90% male and 10% female, which is what we have, the opposite obviously we have globally, whether that would still be the case. All that we've just said, and I think the answer is it probably wouldn't be. I think there is inherently a sexism that is attached to nursing that as you say, limits things. Going back to interdisciplinary working, I think we are starting to see some really, really good improvements in this way, and I think to be entirely honest, I think our Royal College hasn't been as vocal in the international space as it should have been. Elsa and myself have been in post for about a year, so we're working with many others to improve our global profile. And in humanitarian settings, I think there is still some way to go, but I think things are definitely moving in the right direction. And I think where the nursing voice hasn't always been considered, it is more considered now than it ever was before, because people are starting to recognize, as your example pointed to, where nursing is not in evidence, there are some real structural challenges with healthcare delivery, and if you don't address the nursing element, you don't fix it. And I think that comes out in all sorts of places. And I think we are starting to get a generation of other health workers, doctors, physios, paramedics, who are starting to understand nursing a little bit more. And that's from combined curriculum, it's from shared exercises together, it's from multidisciplinary learning that we see in high resource settings. So I think all of that is contributing and helping, recognizing our differences, but also recognizing that together things are much better. So I think I would say that is an area of real hope, but we just have to make sure that continues and we don't slip back into the sort of silos that we were in 10, 15 years ago.
So Elsa, something that Marcus said earlier, and I'd really like to get your thoughts on this, is around adoption of technologies and or innovation. Marcus' notion towards just the cold chain process of being able to keep vaccines cold, and having solar paneled fridges that you can enable cold, preservation of cold chain. Could I get you to speak to any technological innovation that you're seeing in the humanitarian context that is really starting to bridge the gap between some of these fundamental issues?
Yeah, that's an interesting question, because it is a common thread across programs, the use of technology, and how can we use technology to improve the work of nurses and the programs and the outcomes, and it has been around a while and it does play a massive role, but we can't overestimate its power. We kind of have to understand it in a context, because if we're creating this massive technology that serves only one purpose, perhaps we need to think about its applicability and in particular contexts. So we are using a lot of chat apps which are being massive in improving communication, spreadsheets, Word documents, Google Drives, and this is not advertising anything, but it is just these easily accessible tools that don't require a subscription, that don't require a massive bandwidth, that people are using to be more interconnected. And I suppose that technology in global health is really helpful to keep people connected, so that this concept of partnership can work better, and so we feel a bit closer. But then there's also we can also fall into the culprit of trusting technology too much. A good example of that is the digitalization of medical records, which we have had in high-income countries, in the UK particularly. It hasn't been a smooth process, but it's the majority now of healthcare records are digital, and there's an attempt to implement that in certain programs in low middle income countries, and it's happening alongside a shift from communicable to non-communicable diseases, because we have more complex patients. We have, like we said before, a shift towards multidisciplinary teams that need to access records at the same time from different geographical areas. But we need to be really careful, because the main issue here is that if we don't include nurses in this process, if nurses are not part of the technology shift, then we're running the risk of making mistakes and it not being effective. Because if nurses are the ones that collect data, and if they don't know what they're collecting, and if they don't know what they're using, and if they're not being taught in that technology, then there's no point.
Indeed, absolutely. So just coming to land on the conversation, actually, just two more quick-fire questions. One would be really just, and speak to both of you actually, but Marcus, maybe you first. There's just a surprising or indeed transformative experience in your humanitarian nursing career, which is just in a way made you think differently, or really just stuck with you.
So I would say the coup in Myanmar has been the sort of transformative one for me, certainly in the last decade. I'd visited the country many times, like 14 times before the coup, working on various programs, and then the coup happened. Of course, we couldn't go, and so you sort of sit around just sort of thinking, God, this is awful, and feeling very helpless. And then, after a few minutes of doing that, you think, well, what are things that we could do? What are practical things that we could do? So we, set up a website very quickly, which provided people with clinical guidelines. We did a whole lot of YouTube videos with our Burmese diaspora colleagues, which was one of the things that, was really important, because when the hospitals all sort of fell apart and dissipated, it meant that there were very small numbers of clinicians gathered together in different areas, and so it was really useful for them to have clinical guidance on their phone. And then for some people, we were able to sort it out so they had mobile data, so they could access some of our content. So I think for me, the transformative process has been really around, and it's funny, it goes right back to the beginning about, what can we take from one place and put in another. And COVID had given us all this ability to use Zoom and to use online learning, and applying that to a conflict setting, which is basically what I've spent the last 4.5 years doing in Myanmar, has been a really transformative experience. Of course, it's not everything. I'm not sort of naive enough to think that you can do everything from your armchair in London. But I think what it shows us, and I think what it shows in many conflict areas, is if we've got a bit of internet connectivity, there are ways and means in which we can be humanitarians and useful, and all of that stuff. And so I would encourage people not to be discouraged when a terrible crisis erupts in the country. Think instead about, well, what are the ways in which we can do stuff? We just have to pivot and think about things differently.
Elsa, to yourself.
I mean, lots comes to mind, but I guess that's one of the things that most marked me was in Zimbabwe, seeing severe malnutrition. It's not a country where you would see severe malnutrition very often, but we saw them in orphan children, HIV orphans, and they were living in a village there was no food insecurity in that particular village, but they were just left to neglect because of the HIV stigma they carried from their parents. And I was 27 at the time, I'm quite angry at the world that it's a very unfair place. And at the same time, I remember reading, looking at there's a photography book about the 90s crisis in the Sahel, the food crisis and the conflict. And in one of the editions of that book, there is a prologue that talks about the fact that it's only because of geography and it's a lottery that we are subject to conflict and famine and injustice. And sometimes it's completely random, but I don't think the Western world grasps that entirely, that it's due to a mere chance and luck that we are where we are, and we're not in a conflict area. So yeah, I suppose it's difficult after experiencing that and after realizing that, not to become, not to make comparisons and become quite cynical, but you have to choose between being angry and being desensitized. So I choose rare moments of anger and motivation because it resonates more with me. Because I think that globally, and what made me realize is that globally, all this experience, there's more similarities than differences between us. And it's just a matter of luck. So if we're lucky enough, maybe we should be doing something about it.
Oh, that's powerful. That's powerful. Absolutely. Absolutely. So just to finish off, actually, for people listening to this, and I'll come to both of you just briefly. Marcus, if I could initially get you to speak to, if there are nurses considering stepping into global health or indeed humanitarian roles, could I get you to speak to just some advice, top of mind advice to prepare them for the realities of this work?
So I think what we've already said is to think very carefully about where you're going to really absorb all information you possibly can on that place, to recognize your limitations, that superheroes are good for movies, but they're not terribly good for humanitarian crises. And so I think those are the first things to really get the theory stuff in your head solidified before you go. There are courses we've talked about that you can go on and that both of us teach on and contribute to speak to other people, to develop a good network of people that you can talk to when you come back, that you can talk to while you're there, and all of that. And to go in with a recognition that you have skills. It's not at all to say in any context that you're unskilled, because you're not, but to recognize your limitations as well, and to really care for your own mental health and your own sort of safety, because those things are really fundamental, I think.
Elsa, to yourself.
I don't think I can add much more to that, but I guess that that when you do this type of work, you kind of see the best and the worst in the world. So take both and accept that most people will only see what you've seen through mainstream media. So the next time you witness mainstream media, take it with a pinch of salt, and be that annoying friend that worries about war, famine, and injustice, because most people in Europe will have more in common with a Malawian nurse than with a rich tech bro, and humanitarian work will make that very clear.
Yeah, listen, both of what you said just adds to your sense of humanity, and rather than detract, I think it adds to your character, and to your perspective in life. I think it very much, I can echo all those points actually, and how versatile it makes you, but also fundamentally grateful. As you said, also how grateful we, all three of us, are for winning the lottery as to where we were born and raised. And I think being in those contexts enables that gratitude and continually. So yeah, that's powerful. Listen, thank you both for the last hour. It's been fantastic just to walk through your experiences, your perspectives, and where some of the gaps lie, and where you're closing the gaps as well. So it's been fantastic. Thank you both.
Thank you, Eoin.
Thanks very much.
Thanks for listening to the episode. please feel free to rate, review and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical and performance medicine. Thanks again.